Okay, welcome back to part 2 of the lecture on diabetes mellitus treatments. In part 1, we did an overview of type 1 and type 2 diabetes and treatment goals, and talked about the use of insulin in both type 1 and type 2 diabetes. In this lecture, we'll talk about other parenteral agents that we can use in diabetes, and then we'll talk about all of the oral agents that are used in type 2 diabetes. So again, we're going to start with some other parenteral agents, so agents that we inject for diabetes besides insulin. Insulin is obviously the primary injectable agent that we use, but we do have some other agents that can be either added on to insulin therapy or can be used in conjunction with oral therapy. The first thing we'll talk about is pramlintide. Pramlintide is a synthetic amylin analog. So amylin is a substance that is secreted from our beta cells along with insulin. So like when we eat a meal, the beta cells release insulin and they release amylin. We don't talk as much about amylin, but it is something that the body releases in order to kind of assist with insulin. So we have our own version of amylin that we can give. It is injected subcutaneously, so it's given sub-Q immediately before meals. So subcutaneously immediately before each meal. And this is used as an adjunct, so in addition to mealtime insulin in type 1 and type 2 diabetes. Now, I will say the latest recommendations that I read for type 1 diabetes do not recommend this because there's not long-term data showing its safety and efficacy. So type 2 diabetes is the population that it could still be used in. And then, there's always new studies coming out, so I would keep an eye on up to date and just, kind of keep an eye on what they're saying, because as we have more and more information coming in, we might find that it does, start to get recommended more for type 1 diabetes. But the goal for this, or the idea for this, is to be used as an adjunct to mealtime insulin. What the pramlintide does is it helps to delay gastric emptying and improve the satiety, like improve that sense of fullness. It also decreases postprandial release of glucagon. When you eat, your body releases insulin, and then after there's a release of glucagon. This decreases that postprandial release of glucagon, which would then, decrease breakdown of glycogen and gluconeogenesis that happens later. The major adverse drug effect of pramlintide is hypoglycemia. It's given with insulin, and insulin can already cause hypoglycemia. This increases the risk of hypoglycemia considerably. So if this is going to be added on to insulin, we decrease the mealtime insulin by 50%. Basal insulin stays the same, but mealtime insulin would be decreased by 50% to help avoid severe hypoglycemia. Other adverse drug effects that are possible with pramlintide include nausea and vomiting, anorexia. There is, again, a sense of fullness and delayed gastric emptying, so that can, decrease hunger and lead to some anorexia. And nausea and vomiting as well comes from that. As far as contraindications go, this should be avoided in patients with diabetic gastroparesis because it does delay gastric emptying. So if there's already issues with gastric emptying, you don't want to worsen those. Also avoid in creol hypersensitivity. Creol is a component that's in some insulin preparations. So, if patients have had hypersensitivity reactions to insulin preparations with creol, they cannot take this either. And then finally, hypoglycemic unawareness. Again, I talked about this in the part 1 lecture, but some patients are not good at identifying signs and symptoms of hypoglycemia, either because they're on medications that block a lot of those, or because they're elderly patients who might have dementia. But if you have patients who are not good at identifying hypoglycemia, or they they can't manage the hypoglycemia if it occurs, then you do not put them on this, because this does increase the likelihood that they would experience a hypoglycemic episode. Another class of parenteral agents that can be used in diabetes, specifically in type 2 diabetes, are the GLP-1 agonists. GLP-1 or GLP stands for glucagon-like peptide. So glucagon-like peptide 1 agonists. The drugs are written down here at the bottom. Exenatide is a common one. Duaglutide, albiglutide. Notice they all end in tide at the end. The GLP-1 agonists stimulate the GLP-1 receptor to increase glucose-dependent insulin secretion. The kind of overall effect of this is delayed. So we increase glucose-dependent insulin secretion. So this is nice because it's increasing insulin secretion, again, in a glucose-dependent way, as opposed to just giving straight insulin, regardless of glucose. This does show delayed gastric emptying as well, which again influences this enhanced satiety. So we see decrease in eating in general and some weight loss associated with this. We also see decreased postprandial glucagon, which again, glucagon ends up causing increased blood glucose. So by decreasing postprandial glucagon, we decrease some of the postprandial increases in glucose that can occur. B-cell proliferation has also been seen in some animal models, but that's not something that we've seen in humans. Overall, again, the increase in the increase in insulin secretion and the improved satiety, decrease in postprandial glucagon, all of these lead to a decrease in blood glucose, a decrease in the hemoglobin A1C, and something else that we see that's really helpful in type 2 diabetes is we see weight loss. We do see weight loss in patients who are on GLP-1 agonists. The GLP-1 agonists, again, are used in type 2 diabetes. They're not currently recommended in type 1 diabetes per up to date. There were very modest decreases in the hemoglobin A1C, but there was a much greater increase in hypoglycemia. So when we look at the risk to benefit ratio, there was a big risk without very much benefit. So as of now, they are recommended for type 2 diabetics. We do also see that these reduce cardiovascular events and cardiovascular mortality in patients in type 2 diabetic patients. So when we look at the GLP-1 agonists, a major difference between the different agents is their kinetics. So they can be dosed anywhere from twice daily all the way to once weekly. A, D, S, and E. So Meglitide, duaglutide, exenatide, Sulfonylureas. I don't know if you can see the circle here underneath my camera. These are all available in once weekly dosing, so that's nice. They are given via subcutaneous administration. So again, these are other parenteral agents. They do need to be injected. There are long-acting and short-acting agents available. Exenatide needs to be avoided in severe renal impairment. Adverse drug effects, nausea, vomiting, diarrhea, constipation. So mostly we see a lot of GI adverse drug effects with these. Pancreatitis is possible. And because of that, we do avoid in patients who have, so avoid with chronic pancreatitis. Finally, these are contraindicated in patients with a history of some thyroid and endocrine cancers. Again, we see C-cell tumors possible in rats. Now, it's unknown if there's any association in humans at all. We haven't seen this in humans yet, but because we did see it in animal studies, there are warnings, so we just avoid it in patients who have a history of, thyroid and endocrine cancers. Notice here under adverse drug effects that these do not cause hypoglycemia themselves. So just the GLP-1 agonist itself does not cause hypoglycemia. The insulin does, but the GLP-1 agonist does not. Okay, that's it for injectable agents. Now the rest of the agents that we'll talk about are oral agents. We'll start with metformin. Metformin is a biquinide. Metformin is kind of standard of therapy when it comes to type 2 diabetes. It's been around for a very long time. It's very effective. This is the first line agent for type 2 diabetes. The way that metformin works is by decreasing gluconeogenesis in the liver. And this is a big kind of part where glucose comes from in diabetes. Remember, there's this balance between, we eat food and then insulin is released, and that allows us to use that sugar and pack the sugar away in the liver. Then when we haven't eaten in a while, or when we need to fuel our cells, the liver breaks down that sugar and releases it. The liver is also able to make new glucose molecules for us. So, if our cells say, hey, we need some sugar, then the liver is able to make brand new glucose molecules and release them. And that happens in diabetes. Remember, even if we have a lot of sugar, if we're not able to get that sugar into our cells feel like they're starving, right? And we try and make more sugar for them. So the liver does gluconeogenesis, which literally means making new glucose, or giving rise to new glucose. So, and then that new glucose gets dumped on top of the high glucose that's already present in the blood, just making matters worse. So metformin decreases that gluconeogenesis in the liver. It stops the liver from dumping glucose into the bloodstream. Metformin is also associated with enhanced insulin sensitivity, and allows our cells to be able to take glucose up into them. Remember, that's a big problem with type 2 diabetes, right? In type 2 diabetes, remember, patients have insulin to begin with, but they have decreased insulin sensitivity. That insulin is not able to actually get the glucose into the cells. So this improves that ability so that the insulin that's present can actually work to bring glucose into cells. That lowers blood sugar, right? By taking in the sugar into cells allows us to take it out of the bloodstream. Metformin is the initial drug of choice for type 2 diabetes. In the very beginning of the part 1 lecture, I showed you a treatment algorithm for type 2 diabetes. And it said, any patient who has a hemoglobin A1C over 7, any of our type 2 diabetic patients with a hemoglobin A1C over 7 are generally started on metformin, and we titrate that dose up to their maximum tolerated dose. Metformin is given orally. It is renally excreted, and we do see that it is contraindicated in patients with renal dysfunction. And it is important that we monitor renal function, which I'll talk about in just a second. The duration of action of just plain metformin is only about 6 hours. So just like general metformin itself has to be taken multiple times a day. Metformin, however, is available in extended release formulations. So the ER formulation is just taken once daily. There is an extended release formulation that can be taken daily. Adverse drug effects. The most common adverse drug effects of metformin are GI, so nausea, vomiting, and diarrhea. And this is frequently dose limiting. This is why we say titrate the patient up to the maximum tolerated dose. The way that we lessen the GI effects is by doing a slow titration of the dose. We slowly increase the dose every week. You'll increase the dose until you get to the maximum recommended dose. Also, we have patients take the metformin with meals. And that seems to help with that stomach upset. When we look at that dose titration, for example, if we were giving the extended release formulation, they would generally take 500 milligrams daily for 7 days. Then you can increase that to 1,000 milligrams daily times 7 days, then 1,500 milligrams daily. If you're giving, and that's the extended release formulation, if you're giving the immediate release formulation, you'll normally start with 500 milligrams twice a day for 7 days, and then increase that up to 1,000 milligrams in the morning and 500 at night, and you still increase by 500 milligrams a week. The metformin is contraindicated in renal dysfunction. In patients with renal dysfunction, there is a risk of it causing lactic acidosis, and it is cleared renally. So should not be taken by patients with renal dysfunction. We do monitor renal function as well in patients on metformin. It's also associated with B12 deficiency. So that's another thing that we monitor. We monitor renal function and B12. And if necessary, we supplement patients with B12. Metformin use must be discontinued in patients who have acute MI, a heart attack or myocardial infarction, patients who are having heart failure exacerbations, patients who are experiencing sepsis, and the reason for that, any of these situations are situations where patients can have renal dysfunction occur. So, like any situation where the renal function in a patient normally decreases, you stop the metformin for that period of time, because again, there's a risk of lactic acidosis occurring if you were to continue it during that period of renal failure. Also, you discontinue when patients are undergoing procedures using IV contrast, because that is renally cleared as well. Sulfonylureas. Sulfonylureas include glyburide, glipizide, and glimepiride. Sulfonylureas work, notice for metformin that I did not say hypoglycemia. Okay, that's important. Metformin does not cause hypoglycemia. So that's nice. A lot of the other agents, when we look at them, that's like the major risk that we have is hypoglycemia. We don't have that with just metformin on its own. Sulfonylureas. They do cause it. Sulfonylureas work by stimulating insulin release from the pancreas. So because they're increasing the amount of insulin that gets released, you can have too much insulin get released, and that can lead to hypoglycemia. They may reduce hepatic glucose production and increase glucose sensitivity, but the main way that they work is by increasing insulin release from the pancreas. So that means the pancreas has to be able to make insulin in order for these to work. So sulfonylureas cannot be used for type 1 diabetes, right? They wouldn't do any good because the pancreas isn't making insulin. So these are only for type 2 diabetes in patients who still have a working pancreas. Sulfonylureas are metabolized in the liver and excreted in the urine. Duration of action ranges between 12 and 24 hours, so taken either once or twice a day. Adverse drug effects include hyperinsulinemia and hypoglycemia. Again, if you release more insulin than you actually need, then that's going to result in low blood sugar. These can also cause weight gain, which is problematic in type 2 diabetes because it's already associated with obesity. So for example, if I had a patient who was on metformin and the patient was obese, and I say we maxed out our dose of metformin and I needed to add another drug, I'm looking between, should I add a sulfonylurea or a GLP-1 agonist? Sulfonylureas are associated with weight gain. GLP-1 agonists are associated with weight loss. So that might be a good argument in an obese patient to go with a GLP-1 agonist instead, because that's going to help with the obesity. Sulfonylureas, because they are metabolized, caution in hepatic dysfunction. If you look up here at the top, you can see that there are various drug interactions that occur. So you can see drugs that decrease the effects of sulfonylureas, which means they're going to lose their effect and patients are going to have high blood glucose. And then here, this other picture in green is showing you the drugs that increase the effects of sulfonylureas, which is more dangerous in the short term because this would lead to hypoglycemia. I don't expect you to memorize these lists, but you should know that there are a lot of drug interactions that can occur. And the interactions that are leading to hypoglycemia are the more dangerous in the short term. For glyburide only, glyburide, caution in renal impairment and the elderly. Elderly tend to have decreased renal function in general, but the glyburide itself is highly cleared renally. So in renal impairment in elderly patients, it tends to accumulate and lead to some severe hypoglycemia. The other two agents, the glipizide and glimepiride, they are safer in patients with renal issues and elderly patients. So next, the glinides. This is repaglinide and neteglinide. They both end in glinide. So these agents have a similar or overlapping mechanism of action to the sulfonylureas. So the glinides also work by stimulating insulin secretion from the pancreas. They're known as postprandial glucose regulators because these stimulate insulin secretion, same as like the sulfonylureas do. They should not be taken with sulfonylureas. So not with sulfonylureas. Again, because they're both causing insulin release, you could have, a lot of hyperinsulinemia, and that leads to severe hypoglycemic episodes. The glinides have a rapid onset of action, but a pretty short duration. They only are active for about 2 hours, and these are taken associated with mealtime. So you take the medication before the meal, before each meal. They're there to help with that bolus of insulin that occurs with meals. The glinides are metabolized by CYP3A4 and excreted in the bile. So caution with drug interactions with CYP3A4. And caution in hepatic impairment. Notice that we don't have the renal cautions here though. Adverse drug effects with the glinides are hypoglycemia and weight gain. Anytime we see something increasing insulin, we've got weight gain. And then same thing with hypoglycemia. The hypoglycemia and weight gain with these is significantly less than with the sulfonylureas. So like if you were kind of comparing those two, but you're worried about the hypoglycemia, or maybe you're worried about the weight gain, it's a lot less with these than with the sulfonylureas. Repaglinide is contraindicated with gemfibrozil. The reason for this is it's drug interaction wise. Gemfibrozil severely inhibits the metabolism of the repaglinide, so it builds up and then we can see some severe hypoglycemia occur. And then again, caution in hepatic impairment because they are pretty much completely metabolized. So next we'll talk about the TZDs. TZDs include pioglitazone and rosiglitazone. Rosiglitazone is not used as much, pioglitazone is used more, and that's because rosiglitazone is associated with cardiovascular adverse drug effects. So actually it's down here at the very bottom. Rosiglitazone has a black box warning regarding an increased risk of myocardial infarction. So pioglitazone would be recommended over rosiglitazone. So TZDs are agonists at PPAR. PPAR is peroxisome proliferator activated receptor. So PPAR agonists. PPAR, this receptor, regulates insulin sensitivity in various different tissues. So PPAR is a regulator of insulin sensitivity in adipose tissue, in the liver, in muscle, which are like the major areas where we have the insulin receptors. So these help to increase insulin sensitivity. So they're used in type 2 diabetes, where we have problems with insulin sensitivity. TZDs, again, just in type 2 diabetes. Pioglitazone is second or third line in type 2 diabetes. It can be used as monotherapy or combination therapy, and it's just once daily dosing. So typically, first line we know is metformin, but then if we need to add something on to metformin, then usually we would try like a GLP-1 agonist possibly first, but we can, add a TZD. Pioglitazone specifically, not rosiglitazone. Adverse drug effects include liver toxicity. So we avoid in patients who have hepatitis or cirrhosis of the liver, and we monitor LFTs at baseline and periodically. So we monitor LFTs to make sure that there's not already liver problems, and then periodically we check LFTs just to make sure that we're not causing any toxicity to the liver. Adverse drug effects include weight gain, both fat and fluid. This fluid gain, the fat part is just weight gain, but this fluid part can be problematic in patients who have heart failure. So we avoid in severe heart failure. Also, osteopenia is also possible. All right, so next we'll talk about a couple alpha-glucosidase inhibitors. That includes acarbose and Meglitol. These do exactly what they sound like. They inhibit the enzyme alpha-glucosidase, which is a brush border enzyme in the intestines. So what alpha-glucosidase does is, as carbohydrates, like kind of big sugars, are going through the intestines, they get broken down into small little simple sugars. Simple sugars are small enough that they can actually be absorbed into the body. Alpha-glucosidase inhibitors prevent that breakdown of carbohydrates into simple sugars, and that prevents or decreases the absorption of some sugars. Now, glucose can still actually, like glucose itself can still be absorbed, but you can't break down more complex sugars into glucose. I'll tell you what I mean by that in just a second. So because these are just working in the GI tract, they're not, affecting insulin secretion or anything like that, so they do not cause hypoglycemia. However, and they're not associated with a lot of like systemic adverse drug effects, which is great, but their GI effects do tend to limit their clinical use. They are associated with flatulence, diarrhea, and abdominal cramping, so they're not very well tolerated by patients. And note that all they're really doing is decreasing the amount of sugar that gets absorbed from the diet. So that's really something that patients can control with their diet anyways. If they just avoid eating it to begin with, then they don't have to worry about it not getting absorbed. avoid in irritable bowel disease, colonic ulceration, intestinal obstruction. So if patients are already having GI issues, these would not be a good choice. One thing that's important to keep in mind, these don't cause hypoglycemia, but patients could be taking these along with something else that does. If a patient actually is experiencing hypoglycemia, you have to treat that hypoglycemia with glucose itself, because that glucose is already a simple sugar. It's small enough to be absorbed. You cannot treat, sorry, I can't fit this all up here, but you can't treat hypoglycemia with like sucrose, okay, because sucrose is too big to be absorbed. Sucrose is going to have to be broken down by sucrase, and sucrase is also inhibited by this. So you have to treat hypoglycemia with glucose. It's already small enough to be absorbed, doesn't need to be broken down. Okay, you can't treat it with any complex sugars. Okay, so next we'll talk about the DPP-4 inhibitors, dipeptidyl peptidase 4 inhibitors. If you look down here at the bottom, this is kind of showing you like where DPP-4 comes in. We eat a meal, right? And then we have the release of things like GLP-1, for example, or GIP. And remember, GLP-1 is something that promotes insulin function and decreases glucose production from the liver. We like GLP-1. Remember, some of the drugs we use are GLP-1 agonists. So GLP-1 is good for us. GLP-1 is broken down by DPP-4. So DPP-4 here inactivates that. So these drugs here, they all end in gliptin, if you notice, allogliptin, linagliptin, saxagliptin, sitagliptin. These DPP-4 inhibitors, they inhibit DPP-4 so we don't break down the GLP or GIP, so that those are active longer. So these actually kind of have an overlapping mechanism of action with the GLP-1 agonists. And because of that, we do not use them with GLP-1 agonists. So these DPP-4 inhibitors, they're combined with sulfonylureas. They can be combined with metformin. They can be combined with TZDs. They can actually be combined with insulin, but they cannot be combined with GLP-1 agonists because of that overlapping mechanism of action. Overall, by inhibiting the dipeptidyl peptidase 4 and improving the activity of GLP-1, we see an increased release of insulin in response to meals, and we see decreased inappropriate release of glucagon. Which means that would decrease the inappropriate release of glucose from the liver. They can be used as monotherapy on their own, or again, we can see them used with the drugs that I just mentioned previously for type 2 diabetes. Saxagliptin is metabolized by CYP3A4 to an active metabolite. So there are drug interactions that can come in there. All except for linagliptin must be adjusted in renal dysfunction. So in a patient with renal dysfunction, linagliptin would be the one that you do not have to adjust. Just kind of looking at all of the actions of the DPP-4 inhibitors, note they do not cause fullness, they don't cause weight gain. So in combining these with the GLP-1 agonists, which again, they work pretty similarly to each other, GLP-1 agonists do cause early satiety and they can be associated with weight loss. These agents, the DPP-4 inhibitors, are not associated with weight loss. They don't cause weight gain, though, either. They are weight neutral. And so, they're not causing loss, but they're not causing gain either. Adverse drug effects include nasopharyngitis, headache. Infrequently, we can see some pancreatitis, but again, caution in patients who have chronic pancreatitis. We can see some severe joint pain occur. And then alogliptin and saxagliptin have a increased risk of heart failure hospitalizations. So caution in this population, or also in any patients who are at risk who have cardiovascular risks or at risk for heart failure. Okay, the last big class of drugs that we'll talk about are the sodium glucose cotransporter 2 inhibitors. So these inhibit the sodium glucose cotransporter in the PCT of the nephron, the proximal convoluted tubule of the nephron. So typically in the nephron, the glucose gets filtered out of the blood into the capsular space. And then as that fluid starts flowing through the nephron in the proximal convoluted tubule, all that glucose gets reabsorbed back into the body. Right, so we should not be urinating out glucose. Glucose gets reabsorbed into our body. This inhibits the transporter that reabsorbs glucose. So instead of reabsorbing glucose, glucose remains in the urine, and we're able to actually get rid of glucose in the urine. So this decreases blood glucose by urinating that glucose out. This also so we get rid of glucose that way, right? So lowers blood glucose. Also, remember, the reason that diabetes is associated with polyuria is because that glucose in the urine pulls water, right? Osmosis occurs and water follows the glucose, follows the solutes. So because we have more glucose in the urine, we have more water in the urine, and this also ends up causing diuresis, osmotic diuresis, and can lower blood volume and may lower blood pressure as well. These agents, you can see at the bottom, canagliflozin, dapagliflozin, and pagliflozin, they all end in this flozin. They're taken once daily in the morning. Canagliflozin should be taken before the first meal of the day. And they're metabolized renally, or they're cleared renally, so should be avoided in renal dysfunction. Empagliflozin is also indicated to decrease the risk of a cardiovascular death in patients who have diabetes mellitus and cardiovascular disease. So if you have a diabetes patient who also has cardiovascular disease, which is pretty common, empagliflozin can be indicated to improve both. The most common adverse drug effects that we see with these agents are female genital mycotic infections, so like vulvovaginal candidiasis, for example, a yeast infection, the female reproductive tract, as well as the urinary tract infections. And the reason for this is that there is so much excess sugar in the urine. And that extra sugar that's in the urine feeds bacteria that might be present there to kind of fuel a urinary tract infection. And same thing with yeast in the female reproductive tract. All that excess sugar that's leaving the body there in the urine fuels that yeast infection. Hypotension is also possible, especially on patients who are on diuretics, because we're already causing diuresis, and then this is just kind of increasing that. And in elderly patients. Elderly patients are just more susceptible to the hypotension. You should evaluate patients' volume status prior to starting these. And it might seem weird because if you're treating the diabetes, we're talking about blood sugar. Why am I evaluating their volume, their fluid status? but just because these do also cause diuresis. Ketoacidosis is also possible, so caution in patients who are at high risk for ketoacidosis. So patients who abuse alcohol, patients who are calorically restricted, so like restriction of calories related to surgery or illness. All of these patients, so alcoholics or caloric restriction, they're at increased risk for ketoacidosis. This is just a nice chart, this slide and the next slide. I'm not going to read through all of it with you, but this is a nice place to kind of refer to organize all of the drugs. It's organized by drug class, and then you can see the specific agents that are listed, their mechanism of action. You see the effect on insulin. So if they increase insulin, decrease insulin, no effect, etc. And then their risk of hypoglycemia. And this part's really important. Really pay attention to this risk of hypoglycemia, because that's going to guide you a lot in your patients, specifically if you're looking at, an elderly, frail patient. And then little comments here on the sides, kind of little pearls that you guys should make sure you're comfortable with. This is just a continuation with the last few kind of newer classes of drugs. And then this is the same slide that I covered in the part 1 video. This is an algorithm that walks through the treatment of type 2 diabetes. Remember, type 1 diabetes requires insulin injections, multiple daily injections of insulin from the beginning. This is type 2 diabetes, in which we typically start with metformin, as long as it's tolerated by the patient. And then after 3 months, if their hemoglobin A1C is still not at goal, then we can add another agent on board. You guys just in this video saw all the possible agents that we could add. It could be a GLP-1 agonist, it could be a sulfonylurea, it could be TZD. It all just depends on our specific patient and what their risks and needs are.